Good evening, everyone. Thanks for joining me tonight. I want to start off by saying I really appreciate you taking some time out from your schedule to spend an hour with me tonight. It's such a busy week for holiday season, and I appreciate you being here with me. Our topic tonight is current tooth whitening techniques, and we're going to spend the next hour talking about a little bit about past techniques, about the mechanism of tooth whitening, about marketing for tooth whitening, and sort of why it's important to offer whitening in our practices. And then we're going to take a look at some cases. I want to take a look back at whitening over time. Um, a little bit about myself first, I guess. I'm a clinician mostly. I practice in Pittsburgh, Pennsylvania, and I have a fairly large cosmetic practice there. But because I am in Pittsburgh, of course, I see patients from all across the socioeconomic backgrounds and all ages, and I do all types of dentistry. And I do lecturing a little bit. Once or twice a month, I'm out lecturing somewhere, and I do a lot of talking about whitening, adhesive dentistry, ceramics, and smile design. So tonight we're going to talk about whitening. And back in Pittsburgh, I have a whitening center in my office. I realized a number of years ago that we were doing quite a bit of whitening, so we dedicated 2 chairs to doing nothing but whitening in our office. So we're doing lots and lots of it, and I've been through lots of different systems and have done really thousands of cases. So let's take a look back in time. I don't know how many of you out there remember the early developments in whitening. People have been trying to whiten their teeth for many, many decades, if not centuries. Whiter teeth has always been a sign of health and of youth, and sometimes of wealth and success. So as far back when I was back in dental school in the late 80s, early 90s, we were still using superoxide on teeth, which was a 35% hydrogen peroxide. And some of you may remember this little bottle. This is an old picture, so I'm really careful to keep this picture because I'm not sure I could get a picture of that again. But we would whiten non-vital teeth with superoxide, which is a 35% hydrogen peroxide based mixture that would go inside and outside teeth, and then we would activate it with a heat lamp. So really fire those teeth up, and because they were non-vital, they could take that a little bit. It actually did do some whitening on teeth, but it wasn't anything that lasted. Those non-vital teeth would whiten, and then within 6 months be that same amber color again or that dark color. Things really changed in the late 80s, early 90s. Back in March of 1989, Quintessence International published this article by Heyman and Haywood, and it was Night Guard Vital Bleaching, and that really changed everything as far as whitening goes. It made it accessible and easy to all patients and all dentists. So this involved using making custom trays and using carbamide peroxide based materials in those trays and doing whitening at home. And I remember this being a really exciting time when this started to happen. In 1994, Bright Smile laser tooth whitening was launched, and that was really the first in-office tooth whitening system that was marketed toward the public, marketed toward not dentists, but toward the public. And it was really, really an exciting time. I, back in 1994, was walking through a dental meeting and saw a Bright Smile booth, and on a whim, thought it was a great idea, really something that could build my practice. And I signed a lease to get this laser system. So let's just take a peek at that. I would not recommend signing leases on whims to anybody. But for me, this kind of changed the way I practice and changed the focus of my practice to cosmetics and toward elective procedures. The Bright Smile system was really, really pricey. I think it was somewhere north of $75,000, the lease. And it came with 2 lasers. It was an argon laser and a carbon dioxide laser. And it had a really complex setup and a really complex system. So the setup looked a little bit like this, and these are the peroxide-based materials. Each of them had a catalyst and a peroxide. There was a little pipette system. You mixed them together in these wells and then applied them to the teeth. Rubber dam and a syringe was kind of like the precursor to what we're using now. This was like a petroleum-based product to cover gums. And then this was the actual precursor to what we use now to barrier protection for the gingiva. This was a little bit of a wax strip, and you kind of molded it on your patient's teeth. It took about 45 minutes to get them all isolated, if not a little bit more. Very, very carefully pushing that wax onto the teeth, isolating everything up. The rubber dam in a syringe was all over the gum tissue, all over the buccal mucosa, all over the lips, and this peroxide material that we were using, let's just go up here, was 50% hydrogen peroxide. So you'd use it 2 rounds, 1 round with the argon laser and the second round with the CO2 laser. And there was a lot of opportunity for stress and for tissue burns. And I remember when we were doing our training, my assistant was our patient, and the trainer actually really did a big burn on her lip that took about 3 weeks to heal. So we were always really stressed out doing this procedure, but we immediately started marketing this. We charged $1,200 to $1,600 per person to do this, and got a huge response. People wanted it and lined up to get it. It took 2 hours, a couple rounds with the argon laser, a couple with the CO2 laser. It was all doctor driven. I had to do the whole procedure with a very nervous assistant next to me, afraid she was going to spill peroxide on a patient. But you can see really pretty decent results. I mean, we got results from it. Hurt patients, really a lot of sensitivity. But people kind of gutted it out because they wanted the whiter teeth. So that was the kind of the history of whitening. Things are a little different today. The Bright Smile company went through many different morphings of ownership and procedure, and I'm not even sure if they're still around today. But as far as whitening goes, it is the #1 cosmetic procedure that's requested by our patients 20 to 50 years old. Excuse me. It's also the top cosmetic procedure for patients under 20. So this is the top procedure that our patients are asking for. Bleaching's increased more than 300% over the last 5 years. Big numbers. I was really impressed with this one. Americans are spending over $1.4 billion annually on the over-the-counter tooth whitening products. $1.4 billion. It's a lot of money being spent over the counter. In dental offices, it's about $6 million is being spent inside dental offices. And I did a little survey of what we were whitening, what income we had from whitening last year, and we were somewhere between 225 and 250 just in whitening alone in our office. We're doing a lot of whitening. And more than 1 million Americans annually are whitening their teeth. It's a lot of people, a lot of our patients doing that. Is it safe? Is it effective? I think there's a lot of documentation out there, a lot of research over 20 years that says, yes, tooth whitening is definitely safe and it's efficient, it works. And when does it work? It works when you're following the manufacturer's instructions. It is safe and effective when you're following the manufacturer's instructions. So we have lots and lots of people out there that are buying over-the-counter product, and lots of them are may or may not be following the directions as given to them. I find we have a lot of overusage in over-the-counter product, and I think it's important for us to offer this in our practices, not only as a practice builder for us and a driver toward other procedures, but in a way to sort of take ownership of the whitening market. It is our field. Dentists are, we are responsible for the mouth, and I think it's really important that we are taking responsibility for our patients whitening their teeth too. How about the risks? Are there risks involved with tooth whitening? The two biggest risks have been consistently since we started whitening and continue to be today, that there is increased tooth sensitivity and gingival irritation. Those are the two big ones. Those are the ones that cause most of the problems for us. I think statistically, tooth sensitivity happens in about 28% of people that do tooth whitening. And gingival irritation is something that can be monitored and really not happen if we're careful. What about the other risks? And these are sort of newer. This is gathered from studies that have been happening recently. One is that the tooth surface can be roughened and softened a little bit. So when we apply these whitening materials to our teeth, to our patient's teeth, that the surface actually does roughen or soften. There's also an increased potential for demineralization. And the other one that we need to worry about is degradation of dental restorations that can change colors to an unacceptable color. So we have to be careful with these three things as well. And we'll talk about those in a little more in depth as we go through this lecture today. So what exactly are we trying to whiten? What are we trying to do with our tooth whitening products? Tooth discoloration comes from two areas, extrinsic and intrinsic. So outside the surface of the tooth or intrinsically in the enamel or the dentin of the tooth. So what are some factors for extrinsic staining? Well, that's, smoking or pigments in food, metals or minerals that are in foods that we eat that are stuck in the plaque on our teeth or on the surface of our teeth. How do we get rid of those? Well, most of the time we use detergents or abrasives to get rid of those. We're either polishing them with prophy paste, or some people are out there using smoker's toothpaste, which I don't recommend at all. But we're getting a lot of extrinsic staining off when we're prophing teeth. Intrinsic, that's really what we're going to be talking about tonight. How do we get rid of those stains that are inside the teeth, the internal staining, and where do those come from? So we certainly have genetics. We're all born with a genetic code that determines what the basic color of our teeth are. As we age, teeth typically get darker through time. Some antibiotics or other medicines can cause staining, fluorosis, some developmental disorders. And what do we use to get rid of the staining inside? Well, it's all basically peroxide-based bleaching products that we're using. So let's take a look at the chemistry of what's going on there. Carbamide peroxide is a product that's been used for home whitening for a very long time. And carbamide peroxide breaks down when it contacts water to roughly 3 to 4% hydrogen peroxide. So all the products that have carbamide peroxide in them are eventually breaking down to hydrogen peroxide, and that's what's doing the job for our teeth. That's what's making the whitening happen. So hydrogen peroxide is the chemical that we're really going to look at today and see how that's actually working to whiten teeth. So interestingly, the basic mechanism of tooth whitening is still not explained. We don't know exactly what is happening to whiten teeth. We don't know exactly the mechanism that's going on. There is a dominant theory, and that is that the stain molecules are being oxidized into colorless compounds by hydrogen peroxide. So we have peroxide that we're putting on teeth, it's diffusing into the teeth, and when it gets in there, it's oxidizing the stain molecules and it's making them lighter. That's what we think is happening in there. So dental hard tissues are actually highly permeable to fluids, and that's something that a lot of us is counterintuitive to a lot of us, that we sometimes think of dental tissues and enamel as being a static situation, that it's totally solid and impermeable, but actually it really has a lot of flow through the surface, and it has a constant flux of demineralization and remineralization going on. So through the dentin hard tissues, the fluids go mostly through the interprismatic spaces in the enamel and through the tubules in the dentin. And tooth whitening is a dynamic process, and that is initiated by the movement of the material, the hydrogen peroxide-based material on the tooth. It diffuses through the enamel and diffuses through the dentin, and then it interacts with those stain molecules. And when it does that, it sometimes causes the micromorphologic alterations to the tooth surface that we talked about, the increase in susceptibility to demineralization and softening or roughening of the enamel of teeth. And also, it also can work on our restorations that are in teeth. Hydrogen peroxide. It's a colorless liquid with a low molecular weight, and because it has that low molecular weight, it can penetrate through the dentin. And once inside the dentin, it releases its oxygen, and that supposedly breaks those double bonds of the organic material that's in there, and sometimes some of the inorganic material, meaning the minerals in there. And so we want, in order for hydrogen peroxide to work, we believe it has to penetrate through the enamel in the dentin and the dentin. And how do we get it to penetrate through, or how do we enhance that? And that's basically what all of the research has been going to. How do we take our hydrogen peroxide materials and make them the most effective and the most efficient at penetrating the enamel and the dentin. And if we penetrate the enamel and the dentin, are we also penetrating into the pulp? And the answer to that is yes. We are penetrating hydrogen peroxide into the pulp where it's being metabolized inside the pulp as well. And what is the best mix? What are the best combination of factors? How much we're penetrating? What is the concentration of the hydrogen peroxide? How long are we leaving it on the teeth? What enhancers are we putting in it to help it get further into the dentin? So there's a lot of things that can affect the penetration into the enamel and the dentin. One is a higher concentration of peroxide. So you'll see lots of products that have different concentrations of peroxides. Prolonged application. So really the longer it stays on there, the more penetration into the enamel and to the dentin. Increased temperature. If we heat the peroxide up, it'll go further into the dentin. Acid etching and existing restorations. If you acid etch the surface or you have existing restorations, you're going to get more penetration into the enamel and to the dentin. If you have young teeth, big tubules, large tubules, that is going to allow for more penetration into the dentin. Light activation will cause more penetration into the dentin. It won't necessarily cause whiter teeth or a better result, but it does cause more penetration into the dentin. And then the specific formulations and delivery systems. So we're talking about the penetration into the dentin of the hydrogen peroxide. And I just want to be clear that the amount of penetration into the dentin does not necessarily equate to more whitening. So it isn't a direct relationship of more penetration to better whitening. And it's a fine balance of how much penetration, how much applications length, and what kind of other materials are in the whitening product that gives us the best result. And our patients don't all react the same to every single product. So we are looking for products that kind of give us the best results among the most patients with the least amount of risk, the least amount of sensitivity, the least amount of tissue burns, the least amount of demineralization, and the least amount of surface texture changes. So inside the dentin, we believe that there are large organic compounds with these conjugated double bonds. And what happens when the hydrogen peroxide gets in there is that it oxidates that double bond and makes this chromogen lighter. Metallic compounds inside the dentin don't react as well to hydrogen peroxide, so they don't come out as easily. But the organic compounds do react pretty well to the hydrogen peroxide, and we believe that they're being oxidized and they're being made lighter. So color shift is mostly dependent on the concentration of the peroxide and the length of time of exposure. And like I said, all of these manufacturers and research is trying to figure out the best balance between those things, the concentration of the peroxide and the length of time of the procedure. So what do we do for whitening options? We have lots of options on the market today. For our patients, have lots and lots of options. Number one, whitening toothpaste, right? There's a lot of them out there. Most of them contain peroxide. Most of them are over the counter. We have the over-counter strips, and the peroxide's delivered in a strip. It's worn approximately 30 minutes a day. So with whitening toothpaste, I think that it's realistic to expect possibly like a shade or two shift, and that's over prolonged use. The younger the patients are using the whitening toothpaste, the better results they're going to get. Over-the-counter strips, I recommend these for my patients who are younger and just need a little bit of lightening. And sometimes we recommend these for touch-up as well. Rinses and gels. The rinses you can get a little bit of color shift with. I like some gels that are applied directly onto the tooth. We have the tray-based whiteners that we're doing in our office that come with custom-fitted trays. With the peroxyl gels, we dispense the peroxyl gels to them. I also like the preloaded trays, disposable trays that we're using in our office that are office-based as well. And then we have the in-office professional whitening, and that's with higher concentrations of peroxide that's applied professionally. So that's what we're going to talk mostly about today, in-office professional whitening, why we should be offering this to our patients, and what kind of is, what are we using these days? What's available to us? So in-office whitening, it's done with higher concentrations of peroxides. So the peroxides that we're seeing over and over-the-counter products are usually lower. They're 5, 8, 10, possibly 15. The concentrations that we're using in our offices usually range somewhere between 20 and 40%. So a lot more possibility of tissue burns with those. So we have to be much more cognizant of that. And, of course, we're professionals. We're taking care of our patients and making sure they're not getting burnt. So we have to protect the soft tissue. That's absolutely necessary. There are light activations in some systems. Most of it is a 30 to 60-minute treatment time, and we can expect some decent shade shift. 1 to 5 shades can be attained. Light activation, there's always so much talk about this. Is it necessary? Is it effective? Is it harmful? Do we increase sensitivity? There's photoinitiators in some systems. I think almost all of the research bears out now that light activation um, may or may not be may or may not produce better results. That we can get really similar results without light activation, and light activation may or may not have better results than non-light activation. I use light activation in some cases in my office, mostly because I have certain patients that expect it, that they feel like they're getting more if they're under some sort of light. Certain patients that have been with us a very long time, that have been whitening a long time. There's a new laser out, the KPT laser, that has some research that says that it is actually getting better results because of that laser. I think we'll see a little bit more of that in the future. And the other thing I want to talk about is increased sensitivity. Are we getting increased sensitivity with light activation? And I think if there's any heat in the lights, that we need to worry about that we may be getting increased sensitivity, and that's something we should consider before we're using lights. How about marketing for whitening? I said we did quite a bit of whitening in our office, and we've been doing it for 10 years. And I became accredited by the AACD about, I guess, 11 years ago. And when I became accredited, I wanted to do more elective cosmetic procedures. So we started marketing for whitening in our office. And we do internal marketing, we do social media. In the past, we've done a little bit of radio and TV. But I find when we market for whitening, we we not only get whitening patients, we get referrals from our existing patients, and it drives a lot of elective cosmetic procedures to us. And we'll take a look at a couple of patients later. I'm going to talk to you about our two biggest social media campaigns. One, we always market right around this time. Do you know someone who's dreaming of a white Christmas? On social media, and it always is a great response for us. And we sell gift certificates for people to come and have whitening done in our office. And then in the spring, we do Not Only the Bride Wears White, which is also a pretty successful campaign for us. So please feel free to use those, and I hope you get some success like we did. On our current patients and on our health history intake form, we ask two questions that I think are really important. Do you want whiter teeth? And are you happy with the way your smile looks? And both of those have a yes or no check box next to them. So you can't kind of just breeze right through them. You have to check yes or no. And what this does is open up a conversation for us. So anybody that checks, do you want whiter teeth? Yes, we can initiate a conversation with them. We say, my hygienist or my patient care manager will say, I see you said you want whiter teeth on your health history form. Let me tell you about what we can do for you here, as opposed to, would you like me to tell you about what we can do to whiten your teeth? Because it allows it to be a little bit more directed. So do you want whiter teeth? Yes. So great, let me tell you about what we can do here. And it kind of opens the conversation up a little bit. And it also allows us to take some photographs pretty easily. We always say, let's take a few photographs, and then we'll put them up here on the computer, and we'll show the doctor and see if she has any suggestions for you. The second one is, are you happy with the way your smile looks? Yes or no? Yes. Okay. No. So I see you're not happy with the way your smile looks. Let me take a few photographs and let's talk about what we might be able to do. It's sort of a directed marketing that allows our allows our staff to open up conversations that may not be opened up otherwise. And that's on our medical intake form and on our medical review. So when we update our histories, we ask that again, just in case people change. So let's talk a little bit about in-office whitening. That's my daughter, who is a absolute whitening junkie. She just cannot get enough of it. I walked into the house about an hour and a half ago and said I was doing this webinar tonight, and both my daughters and my niece were there, and they both said, both daughters and niece all jumped up and said, "Wait a minute, I need to get whitening. I need to get whitening while I'm home on break." So, I think my kids are indicative of what their whole age group is about. They really are concerned about the color of their teeth. So this is the procedure that we do in our office. For in-office whitening, we first have a consultation. During that consultation, we talk about the procedure, we talk about different options for the patient, and we take photographs. And if they agree to the procedure, they sign consents at that point, and we dispense some desensitizers. We then do a 2-visit procedure. If you do whitening and do a single procedure without any other backup, I think you can expect to get a color shift at that appointment that lasts roughly between 6 weeks to 6 months, that you'll immediately get relapse, and it isn't a nice long-term result. If you do a single procedure and do take-home trays or dispense some material to take home, you'll get better results. And I find with people that have serious staining, or older people that have age-related staining, that we do a 2-visit procedure that works really nicely. That they will get an hour of whitening in our office. We'll send them home with some whitening material to use in between. A week later, they come and get another procedure, and then they do 2 or 3 whitening sessions at home with material at home after that, and that gives a really nice long-lasting whitening. We also offer touch-ups in our office to all of our patients, and we'll touch on that a little bit toward the end of this webinar as well. We charge between $600 and $800 for this procedure. It depends. If I'm seeing them for a 2-visit procedure, it's usually toward the $800 range. A 1 is $600. We also try to have payment done at this appointment as well. My hygienists do all of the whitening, as a matter of fact. So this consultation is about 15 minutes of doctor time, and the rest is happening in the hygiene chair. So the protocol in our office is the consult and consents, and then we dispense desensitizer. I have them use it 3 days prior to whitening. This is just what I'm doing in my office, and it seems to be working out well for us. We have reduction in sensitivity because of that. We then have a 1-hour whitening appointment where we isolate, whiten, and then we dispense some home trays or some preloaded tray material, or a hydrogen peroxide based pen, and we have them use that for 3 to 5 days. Not the day they whiten. So the day they whiten, they don't do anything, and the next 3 to 5 days they whiten at home for 30 minutes a day, or with a tray, or with a like a pen application. A week later, they return, and we do another 1-hour whitening appointment where we isolate, whiten. We take some post-op photos that day, and I dispense a few more home trays, about 3 more days of home material. And then we also dispense remineralization paste. So we are trying to minimize sensitivity prior to the whitening, and we're trying to minimize the demineralization after the whitening by dispensing the remineralization paste. And then we touch up as needed. Typically what we tell our patients is, if they go through this protocol, or perhaps it's a 1-visit protocol with some whitening material at home, that they can expect, if they don't do any touch up at all, that their teeth will relapse back to where they are now in 3 to 5 years, depending on what their habits are. If they're smokers, if they drink a lot of red wine, if they are eating a lot of foods that are staining their teeth. But if they touch up periodically, and we usually recommend once a year touch up to our patients, that it can really hold pretty indefinitely. So we offer a touch up in our office as well, and that is a 1-hour appointment. We charge between $250 and $300 for that in the hygiene chair as well. So you can see how this sort of becomes additive, and that's how we've really built this whitening program in our office. And my hygienists really enjoy it because they're spending time with the patients. They're not waiting for me to come and check them, go back and forth. They're really working pretty independently the whole time, and it's kind of a big wow factor. They really get some nice results, and patients are happy about it, and they're happy to come and have it done. Oftentimes our touch-up is done at the time of their recall appointment. So the consult appointment, we take the 4 photos, we do a smile evaluation, we discuss the procedure a little bit, we have them sign consents after the risk and benefits are talked about, and then we dispense desensitizer. The desensitizer that we use most of the time is this product from Ultraden. It's an Ultra Ease, it's called. It comes in a plastic disposable tray, and it's the potassium nitrate with fluoride. There are lots of whitening agents that now have this in it, so we don't do this step with everybody anymore. Like when we're using the materials that already have the potassium nitrate in it, we no longer dispense ahead of time with this. So just a quick run through of this procedure. We're going to apply a little lip protectant to our patient. We put some dry angles in on the corners, put a cheek retractor in. There's also a bite block, and it holds the tongue back. And then surgical cotton rolls in the buccal space, upper and lower. Then we're applying the liquid dam, which I guess we probably all know. It's a light-cured resin material that acts as a barrier and doesn't allow the peroxide to seep onto the tissue. The key to this is that you're drying these teeth off very well, and that you're taking the tip of that material, the tip of that applicator, and you are placing it right into the inner proximal areas and kind of giving it a little squeeze in there on dry teeth. And it works really nicely to seal that off. If the teeth are wet or you're not getting it all the way into the papilla area, you're going to get some leakage. That's cured on, and there's the total isolation, top and bottom. Can't see any tissue at all. And occasionally we'll put them under a light just for the bling factor. Really nice results. We get some good results with this. So there's a case. This is a case of, a lot of age-related staining, and I think this is a nice case to see. You see his crowns matched his teeth pretty well here, and over here they're much darker. We really can get some nice lightening out of this. How long will this last again? Like I said, I think it will last 3 to 5 years. If you don't do anything, it'll slowly fade back over time. Excuse me. I'm sorry, I have a little bit of a cold. I'm hanging in there. It'll slowly fade back over time to where you started, unless you periodically touch up. So we have this gentleman come in once a year. He gets his teeth cleaned twice a year, but once a year at his teeth cleaning, he comes in and we put him back under the lights for a touch-up whitening. Same thing here, some really nice results, some age. This is the toughest stuff to get out, these yellows that have been there for a long time, and you can really get a nice color shift with them. How about let's talk about the risks a little bit. Increased tooth sensitivity and the gingival irritation. So what do we do about those? We looked at the gingival irritation a little bit in the last slide, how we can adequately block that with the rubber dam material. The increased tooth sensitivity, I think it's possible to either dispense desensitizer or to use the products that have the desensitizer in them. Those work really nicely. What about tooth sensitivity? We always tell our patients, for the most part, 98% of our patients that get sensitive during whitening, the sensitivity is going to go away. It's going to be completely gone within 24 to 48 hours. We've had very few cases, and there's very few documented cases where the sensitivity lasts a long time unless there's other factors in play. So gingival irritation, we want to do the barrier protection. We want to do it really well. So I think it's really important that we train our hygienists to do that extremely well and be really cognizant of it. And the other thing that we do is we don't we have a two-chair whitening system. So we have patients in both chairs, and we sort of have somebody checking on those patients all the time. I don't like to leave patients alone whitening. Sometimes their lip retraction will slip, or they'll try to talk or answer their phones, or they try to see themselves in their mirrors. And when they do that, they can get a little bit of peroxide material on their gums or their lips and cause a really nice burn. And then we talked about these risks as well, the surface roughening and softening, the increased potential for demineralization, or the degradation of the restorations and the color change. We don't want that to happen either. What happens if you get a tissue burn? So this was a patient in my office that was not isolated well. So the hydrogen peroxide material crept right underneath that barrier protection and burned the tissue pretty well. And what happens when the patient's in the chair and this happens? They start to say, my gums are really stinging. I really feel a lot of burning on my gums. And you see on the lower, they did a nice job on the lower because there is no tissue burn down there at all. And this is a tetracycline case. So these teeth were um, a little modeled to begin with. And I'm just showing you this because I want you to take a look at the tissue burn. So you get this blanching of tissue, and it can get very, very white. So you immediately want to take off all the isolation, but leave the cheek retractors in place. If you pull the cheek retractors out, they'll immediately flop down on top of your peroxide. You want to evacuate all the peroxide, you want to take off the barrier protection, and you want to irrigate really, really well with water and a high-speed suction. You just want to rinse, 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 rinse as well as you can do. And then you just kind of wait it out. So here's the peroxide burn when we took the tissue off. Took off the protection. This is 10 minutes later. You see it's starting to fade, it's starting to fade, and after 20 minutes, completely gone. So the color returns to the tissue. And unless you really burn somebody, you're going to get this. You're going to get this healing or this immediate 20 minutes restoration of the color of the tissue without an ulceration. I have had patients use over-the-counter products or even tray products that they've overloaded and really burned their tissue and had ulceration and needed more care. But for the most part, this will go away if you get the peroxide off and really rinse well. How about increased susceptibility to demineralization? Just a word about demineralization. The surface of our teeth is a dynamic situation. The surface of our enamel is constantly undergoing demineralization and remineralization. And I think this is a new concept for many of us. Many of us thought that the surface of our teeth was sort of stagnant and that you could demineralize, but remineralization was not really an option. But that's what's happening on our teeth all the time. The calcium and phosphate ions are being released out of the enamel in acidic environments and in the basic environments, and when there's basic saliva, that they're being remineralized. So whitening actually increases our susceptibility to demineralization, and we want to do something about that. So we've got this tooth surface that's a balance between the demineralization and the remineralization, and it depends on the acidity of the surrounding environment. And this demineralization, remineralization is the caries balance. Too much demineralization, we have caries, right? So the pathologic factors involved are if we have acidogenic bacteria, if we have reduced salivary flow, if we have more frequency of fermentable carbohydrate ingestion, and if we have our teeth whitened, we're more susceptible to demineralization. The protective factors are the other side of that coin. Fluorides, calcium phosphates, proteins, antibacterials in saliva, and antibacterials such as chlorhexidine. And we also have products that help aid in the remineralization. So here's a list of the products that you can use. We are mostly using MI paste. And we dispense that to our patients after they have their teeth whitened and have them use it till they're done with their tube. There's, the Novomin paste, there's fluoride varnishes, there's high dosing fluoride rinses, and there's other options they can use, but I think we should consider doing that after we whiten, just to be on the safe side, to minimize those risks to our patients. So let's take a look at a couple of cases. This is a patient of mine who came to me because she was interested in whitening her teeth, and she had peg laterals. So this happens pretty frequently in our office, where we're doing combinations of whitening and cosmetic work. So she was in our office to have her 7 and 10 prepped for porcelain restorations, and in this picture she has her temporaries on. So she spent the morning with us, about an hour and 45 minutes, getting all of her records, all of her photographs, some anesthesia, getting that prepped, getting an impression taken, doing all the shade mapping of her prep shades, of course, not her superficial shade, and then getting provisionals on. So after that hour and a half or so of work, we still have to do some whitening on her. So I really like the Polo office whitening because it's really fast. And I think it's hitting on maybe one of the ideal combinations of percentage of hydrogen peroxide and exposure to the tooth. So we're doing a high percentage of hydrogen peroxide, but a lower exposure. It also has a neutral pH, and it has the potassium nitrate built in that we talked about a little bit. So here she is a little closer. You see I've got provisionals on 7 and 10, and we're going to whiten her other teeth. And when I do this in conjunction with cosmetic work, we usually prep and whiten on the same day, and then we have them whiten at home for a few days after that. Then we allow them to stabilize, and then we have them come back for the shade mapping, because I want all of the rest of her dentition to be really stable before I shade map the color that I'm going to make these porcelain veneers, right? But I also don't want to whiten ahead of time, because sometimes when we whiten ahead of time, people are so satisfied with the color of their teeth, they don't go ahead with their cosmetic work. So I find it best if we prep them, provisionalize them, and then whiten them on the same day. Come back about a week later, to about 10 days later, we evaluate the provisionals, decide if they look the way we want them to look. If they do, if the patient's happy, if I'm happy, then we photograph them and we impress them, and we ask our ceramists to make them in the size and shape we know already looks good for them. And we also do our shade mapping at that time. We've allowed for stabilization. We always talk about whitening with anybody we're doing any kind of anterior work on, even if it's a simple composite, because so many people want whitening, and we don't want to do a restoration and then a year later have them say, wait, I want to whiten my teeth. Well, I can only whiten as far as that restoration is, because I can't whiten that restoration. So we always talk about it early. So here's our patient. This is Tara. We're whitening her with the peg lateral restorations. So I'm going to use that bite block with the cheek retractors built into it. And the same way we did before, some dry angles, some cotton rolls, cheek retractors, and we use a rubber dam napkin on the outside, which is really nice to keep everything dry and kind of keep her lips out of the way. And then we're going to air off those areas really well and then apply the barrier protection. So here we are applying the barrier protection. And then we're going to fill in everything between that and the cotton rolls, top and bottom. And then we're going to use this Pola Office, which is kind of a nice viscous material. I like it because it sticks to the teeth really well. This is a 37.5% hydrogen peroxide material. I don't know if you can see that or not, but you put it on for 8 minutes 3 times. So basically 24 minutes of whitening as opposed to an hour of whitening. And it's hitting a really nice balance of a high concentration of peroxide, but a shorter duration. And we're getting some very, very nice results with it. I'm enjoying it a lot. So it's 37.5%, and I like to use this pen. This is one of the things I really like. It's a peroxide-based pen that instead of giving them trays or disposable trays to take home with them, then they simply use this and paint it on their teeth 3 to 4 times a day over the next 10 days, and it continues to whiten. 5 days of the Polo paint 4 times a day. Then we let them stabilize for about 10 days. Then they come back for the restorations. I have patients that are really enjoying this too, kind of as a just something to carry around in their purse. You can paint it on pretty much anywhere, and it dries on your teeth pretty quickly. I have patients that have been telling me that it makes them feel like they have really fresh breath too, which is nice. So if you have patients that are concerned with kind of cosmetics or you know, that are you know, concerned about the way their appearance is, I find they really like this little pen. Here's another patient. We have many patients like this that come to our practice, right? We see these guys all the time. People that come in that are here for a routine cleaning and exam, and we take a look and we see some other things going on in there. So this guy's chief complaint, he was 18 years old, his mom came in with him. His chief complaint was that he doesn't have one. I say, Jason, how are your teeth doing? Anything going on? He doesn't have any complaints at all. But his mother's chief complaint was he doesn't brush his teeth enough and they're yellow. So she thinks his teeth are dirty. So because they've answered the questions like that, we take some photographs and we pop these up on the screen with the mom and the boy in the room. And we start talking about kind of what's going on in his mouth and what we can do. We do like a mini smile evaluation for him. And his mom has absolutely no idea that he's got this fractured tooth because she never sees inside his mouth anymore. She just sees that he's not smiling a lot. She thinks it's because his teeth are dirty, and it's, affecting his self-esteem a little bit. It's affecting his smile. And, of course he's adorable, but he's not putting himself out there as much as she thinks that he should. So we do like a mini smile evaluation, and we're going to look at this kind of simplistically through the white, the pink, and the black. So we're first going to look at the white factors, the teeth, the pink, the gingiva, and the black where we're missing things, right? So if we look at him, his teeth, first of all, the first thing, of course, we all see is that fracture on tooth number 8, that composite that's broken a little bit on tooth number 8. On tooth number 9, he has that hypocalcification lesion, and basically he's got a pretty yellow teeth everywhere. If we're looking at the pink, we might want to consider his gingival heights. This tooth looks a lot shorter than this tooth. So maybe a little bit of sculpting here after we evaluate whether or not that's possible to remove a little bit of gingiva with like a laser, with like a Picasso light laser. And these two teeth don't look even either. This teeth looks a little shorter than this one. So a little bit of gingival sculpting, a little bit of asymmetry. Black-wise, we've got no concerns with this guy, right? Like, he has really nice teeth. We really could do him a world of good by whitening him, getting rid of this stain, and then redoing this restoration. So same thing. Are you happy with the way your smile looks? Would you like whiter teeth? They've answered those questions on our form. It gives us the opportunity to say, I'd like to take, my hygienist says, I'd like to take a few photos for the doctors. I'd like her to take a look at the bonding on your front tooth. And then we put those photos up on our screen. And when they're big like that, mom is really pretty willing and anxious to get that taken care of as quickly as she can. So here's our guy again with his retracted view. And what are we going to do for him? We are going to do a little bit of sculpting here, gingival sculpting on number 10 to even those out a bit. I'm going to micro abrade this tooth a little bit. It's a procedure where it removes brown stains very nicely and white stains pretty decently too if they're superficial. A little micro abrasion there, and then whitening, and then we're going to restore this central incisor. So here he is afterward. Big difference for this guy. So a little bit of gum sculpting, nothing crazy on there. We did microabrasion here, then microabrasion, then we did the whitening, and the last thing we did was restore this. So this is the Polo office for a session in office, and then we sent him home with some whitening material to use for about 5 days afterward, and then we stabilized, and then he came back and we restored this restoration here. So big difference, and I think this picture is really telling. He does not want to smile for us at all in this picture, and you can see he's definitely smiling more in this picture. He's happier about it. He feels better about his smile. So, this is something that I feel really good about, and I feel like we can really help our patients do this, offer this to our patients. And the other thing that also helps is it takes it from, on that particular guy, on this guy, we went from possibly just doing a composite restoration on this distal corner to a little bit more of a procedure, and not a whole lot more chair time for us. Gingival sculpting and the microabrasion took about maybe 20 minutes to do of chair time. This restoration takes me the same amount of time. It takes me about an hour and a half to do that restoration, doing it nicely. And then the whitening and the hygiene chair. So instead of just a simple composite restoration on there, we're able to do more of a elective cosmetic procedures for him, and this was about $1,600 worth of care for him, and mom was happy to do it, and I think his results are really nice, and they were really pleased with the results. Just sort of helps us offer things patients want and deliver them in a way that makes them happy. This guy came with this restoration. His mom was concerned about this composite restoration on there, and you see he has a lot of other stuff going on as well. And he had lateral incisors missing, and he was orthodontically closed, so he's canines in the position of his laterals, and one canine doesn't look too bad, and the other one looks really, really short because of the tissue there. And of course, these two central incisors are pretty heavily filled as well, and he's got pretty yellow teeth. He's got fairly yellow teeth, not pretty yellow teeth. This was 4 restorations on this guy, 4 porcelain restorations and whitening, and I think it makes a big difference, and you can sort of see it in his face too. Really much happier afterward. Now these post restorations, this is 4 restorations in porcelain on these 4 front teeth. Um, I'm always trying to do the most conservative thing we can on there. So we could have put restorations on his first by custom cuspids also to make them look more like canines, but I'm just not sure he would have benefited a whole lot from that, and we probably would have had to prep them a little bit to do that. So we're always weighing what's the most conservative thing we can do to get the results we want. And this guy, I think, needed a little bit more smile, a little bit more tooth, and that's why we made him a little more square. And we tried those out in provisionals and made sure that he liked them, that I liked them, that his parents liked them before we had those made into his permanent restorations. A little bit of a word about conservative dentistry. You know, that's all of dentistry is moving toward the least amount of dentistry we can do, minimally invasive dentistry. That's what we're all aiming for, and that's a fantastic goal. I'm really proud that to be a part of that, to be moving forward. And whitening is absolutely the most conservative thing that we can do for people as far as a cosmetic procedure. So I think that's why so many people are seeking it out, and it's wonderful to be able to offer it to them. Heavily stained teeth like this, we can definitely get some movement on the color of those, but how long will that last and how do we maintain it? So we talked a bit about this, that it depends on the environmental factors, smoking, pigments, beverages, some medications. How long is that going to last? And like I said, we would tell that man that's going to last 3 to 5 years if you don't do anything at all. And that's a situation like that. That's 2 sessions of whitening there with material in between. But how do we do that? How do we touch that up? How do we make that last longer? We touch them up once a year. So we bring them in for an hour in the chair, and we isolate him, or half an hour in the chair, which is really nice with the new product that works so quickly, the Pola. I can do it in a half an hour now. So once a year, we do it at the same day as the recall cleaning. We pre-schedule that ahead of time. So most of our whitening patients know that they're going to come for a cleaning for their next 6 months, and 6 months after that, they're going to have a cleaning and whitening together. And we're going to do just a 30-minute chair time and send them home with a paintbrush, a Pola paint for follow-up after that. We also use these disposable tray products sometimes, Opalescence Go and Venus White. We send a lot of patients home with those as well. We know that patients, I'm trying to run through our last little bit here because I want to save some room for questions if anyone has any for me. We know that patients desire pearly white teeth. It's pretty apparent, right? White teeth have been linked to so many things that are important to us: social competence, intellectual ability, successful interpersonal relationships, and sometimes even psychological stability. So white teeth really affect our self-esteem, especially I think younger people's self-esteem. So it's nice that we can offer this whitening in a controlled environment. They're not doing over-the-counter products that maybe are not as used as safely as an in-office procedure, and we're able to really monitor that and keep their gums safe and do any remineralization as needed. I like this picture. I took this picture not long ago in a drugstore near me. That's actually a Walmart. And just the amount of whitening product and dental whitening toothpaste that are out in the market is staggering. So we are sort of ceding our part of the whitening to over-the-counter products. And I think it's important that we offer it to our patients and have the ability to give them what they desire. I always end with this lady. This is Dorothy. She came to me from her friend and doctor of 40 years. She had been his patient for 40 years. It treated her, her children, her husband, her friends, her family, and she had asked him several times about whitening her teeth, and he's an excellent doctor and does really beautiful work, and I think he did what we all do sometimes, maybe have some sort of judgment or prejudgment as to who is interested in whitening or who needs whitening, and he just didn't address her concerns. And because of that, she came and sought me out to have some whitening done. And when she came, we actually ended up restoring all of her upper teeth. And I know you're looking at her just the way I'm looking at her, and you think, I can't even really see her teeth, right? Can't really see her teeth, but you can tell that she's dressed really beautifully and takes care of herself really well, and is very concerned about her appearance. And she allowed me to prep all of her upper teeth and whiten her lower teeth. And I'm absolutely certain she would have had her dentist friend do that if that had been suggested to her. But the remarkable thing about Dorothy is that she's legally blind and has been for 25 years. So she has not seen her teeth for 25 years. And and still, that was a big concern, enough of a concern of her that she left her friend and dentist to come seek out whitening elsewhere. So we use that as a little reminder in our office. Remember Dorothy. So we don't want to judge anybody, and we want to offer what we can to people. So I want to thank you for listening tonight. I am going to see if we have any questions here. Okay. Got lots and lots of questions. Let me back up here a little bit. One question that I always get asked is how early do you bleach? Well, how young is too young to whiten people's teeth? In my office, we talk a little bit about how you get more absorption of peroxide through dentin, penetration through dentin in younger teeth and dentin tubules. So I think it's really important that we are doing the whitening on younger people and not sending them over the counter. So 14 is my bottom line for whitening in my office, 14 years old, and I do it very controlled and I do it very short. So I would use a product like the Polo. I would do those 3 8-minute sessions with the higher concentration because you'll get less absorption into the dentin, through the pulp that way. So 14 is my bottom number. I have whitened people slightly younger than that. I've whitened as young as 12, where they have been affected by their self-esteem has been affected when they have teeth that are so yellow that their parents are telling me that they are being made fun of or don't feel good about themselves. So I have gone as young as 12 to do that, but it's not regular. It's not happening regularly. Can anyone use Polo paint or is it only for touch-ups? Anyone can use it. I use it for touch-ups just because it's easy for us to use, but anyone can use it at any time. Okay, let me just see here. What is the cost for the follow-up whitening? We charge between $250 and $300, and every once in a while we will run a special on touch-up whitening, and we'll do it for $200. If I've got some hygiene chair time that I want to fill, we will send out an email blast to our patients and do a touch-up whitening, and our chairs fill really quickly. We also use touch-up whitening as a fundraiser. Once a year, we raise money for different charities. We've been raising money for MS the last 3 years in our office. And we will do a fundraiser where we charge $200 for whitening, the touch-up whitening. And we have the patients directly, they do $50 to us and $150 goes to the charity. So we basically charge $50 for the whitening and they make a $150 contribution to music for the MS. It's the Music for MS Festival in Pittsburgh. And that's a big practice builder for us. People love to help and they love to get the whitening done. What is the best whitening kit in the present market? Someone's asking me. Now, like I said before, different kits, different types of whitening are going to work for different people. And you have to decide, like for me, I want a kit that works quickly. I like the Polo because it's a higher concentration and it works quickly, and that works for a lot of people. I do stock Opalescence Boost in my office too for the people that have the darker, heavier staining that I'm going to go and do 2 rounds of whitening on. So I don't think there's one single the best, but I think there's ones that work really well most of the time. And those are the kind of my go-to on both of those. What do you do if pain is felt a half an hour into the process with 35% H2O2? That's a really good question. If at any time during the procedure a patient is getting sensitive, we immediately stop the procedure. We take all the hydrogen peroxide off, take off the barrier protection on the lip, on the gums, rinse, 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 and then pull out the cheek retractors, and then we'll put some desensitizer on them. Like I'll put a Ultradent Ultra Ease disposable membrane on their teeth. and we allow them to sit for about 30 minutes. It usually goes away pretty quickly. I always do it at the first sign of sensitivity, because if you don't, it'll just get more sensitive. We bring that patient back for a second whitening, and almost every time they're able to get through the second whitening, shorter time periods, lesser concentration of peroxide for those people. We just about have 5 seconds left. Thank you all for listening tonight. My email's up on the screen if you'd like to contact me. Good night.